Hello all. So today we'll start with a small case history. Okay. So a small child, a 6-year-old child, was brought to casualty with history of high-grade fever, pain in the throat, inability to swallow for the past 2 days. So when the child was examined, he was toxic with a white patch over the fauces, which was bleeding on touch, and the history of immunization is not very clear. Okay. So for undergraduate students, currently under the new curriculum and things. So some of the history questions are on case-based questions or clinically based questions. So some of the keywords which are note here is a child, immunization history is not known, white patch, inability to swallow, and that patch will start bleeding on being touched with any kind of an instrument. Okay. So today we will discuss about Corynebacterium diphtheria. So basically, when we talk about Corynebacterium, it's a gram-positive bacteria which is non-acid fast. It does not have any kind of a motility. It may have some granules. So these granules can be used for the purpose of identification. And when you stain it, the whole bacilli generally doesn't get stained very uniformly. There'll be some gaps in between the staining. Okay. So because of the presence of granules, the bacteria appears to be a bit of a club-shaped bacterium. And the most common disease what is associated with this particular bacteria is called diphtheria, and the organism responsible is Corynebacterium diphtheriae. There are other diphtheria also, not diphtheria, other Corynebacterium also. So all those things will come under a group called diphtheroids. When you talk about Corynebacterium diphtheriae, they are very slender kind of a rods, thin bacilli. They have a clubbing at either one or both ends because of the presence of granules, and they are pleomorphic, means the shape and the size of the bacilli will mostly be kind of different. Okay, they do not produce any kind of spores. They don't have a capsule. Just like Corynebacterium diphtheria also does not have a motility, and some of them will show amount of branching and septa. What you see in generally actomyces and Mycobacterium. Corynebacterium may also show some amount of branching and septations here and there. Generally, staining wise, they are gram positive and they'll be very easily decolorized. And what granules you see on this bacteria are made of a polymetaphosphate. And generally, what happens is these bacilli, when they undergo multiplication, when they divide, no, they don't completely separate out. Okay, so they uh, remain attached to the parent bacilli in some kind of angle. So at some microscopic view, when you look at it, it looks like a Chinese letter pattern or what is called as a cuneiform arrangement. So these granules, when you try to stain them with Leopard's methylene blue, they are purplish blue in color. So they are called as a metachromatic granules or otherwise called as a volutin or Babe's earnest granules. And generally they are seen at the poles of the bacterium, end of the pole. So they are always called as a polar bodies also. So you can use some special stains. The most commonly used one is a Albert stain. You can also use Neisser stain or Ponder stain for detecting this particular uh, granules as well. When talk about the growing of this bacteria, it is actually a aerobe and generally on a normal media without any kind of an enrichment, the growth is slightly slow. So little bit of enrich the media with either blood or serum or egg, then the growth will be pretty nice. And the most common media what is used is a Leopard's serum slope, which will good growth within 6 to 8 hours. You can use Tilray blood agar in case the person from whom you are taking a sample is a suspected carrier or when you suspect that the amount of bacteria will be less, then you can use Tilray blood agar. Even in acute cases, you can use, so it becomes a selective agar for this particular bacteria. So on a Leoploserum slope, they'll form a circular white opaque discs which will slowly become yellowish in color on further incubation. When you talk about telluride medium, the telluride is a selective agent, so uh, it will prevent the growth of any other bacteria in that particular media. So telluride is converted to tellurium, giving a gray or black color colonies. Okay, and they grow a bit slow on this particular medium. There are some modifications which is called as a Micloids modification or Hoyle's modification. Depend on the infections which are caused, the Corynebacterium Diphtheriae can be classified into three different types. It's called as a Micloid classification. So first one is a Gravis type of an infection where the fatality rate is quite high. It can also have some paralytic and hemorrhagic complications. And, it is prone to cause epidemics. Intermediates again has a high fatality. Hemorrhagic complications are there. It can also cause epidemics. So its paralytic part is slightly less compared to Gravis. Mites is a less fatal kind of a disease, mostly causes obstructive lesions in the air passage, and most commonly seen in areas where Corynebacterium diphtheria is more prevalent. And in most of the patients or people, you will see them as commensals and not actually causing much of a heavy infection. The most important part of Corynebacterium diphtheriae is its toxin, which is a very powerful toxin. And the Gravis and intermediates produce the strains can 99% can produce this particular toxin. Even Mites strain can produce toxins. The toxins are kind of a phage related, so we'll see that, about the phage relation in the next slide. So when these bacteria are isolated from acute cases with proper clinical history and things, all these three types are considered as a virulent strains only. Okay. So A virulent strains where you see is in most in convalescent patients who are just recovering from the infection or contacts of patients or caretakers maybe, carriers or patients who have had a extrafascial infection. Now, the how much amount of toxin is produced depends on the strain which is there. And one of the strain, what we have to note is a Park Williamite strain, which is used for toxin production. Why it is used? It is used, and for this toxin can be toxided to be used as a vaccine. So this toxin is a crystallizable toxin with a molecular weight of 62,000 kilodaltons, and a very small amount, 0.0001 milligrams, is enough to kill a small or average sized guinea pig. This toxin contains of two fragments, fragment A and fragment B. So generally these are combined together. So when they are combined together, the fragment A is covered nicely with this fragment B. So it's an inactive toxin. So once inside the body, because of the help of proteases, the protein splitting enzymes, they will split into fragment A, which is responsible for the toxicity, and the fragment B, which is responsible for binding to the corresponding cells. So if we can create an antibody towards fragment B, this will prevent the binding of the active part to the cell and can prevent toxicity. So this toxin is a liable toxin, means you can uh, convert this into a toxide by keeping at 37 degrees Celsius for 4 to 6 weeks, or exposing it to 0.2 to 0.54% formalin, or slowly reducing the pH to a acidic pH. So this toxin, as far as Corynebacterium diphtheria is concerned, is dependent on the bacteriophage. So as you all know, bacteriophage is nothing but a small virus which infects the bacterium. As far as Corynebacterium is concerned, these phages are called as tox plus phages or corniphages. So once the phage is associated with the bacteria, that is when this will be able to produce toxins. So the lysogenic conversion will happen, and the bacterium will continue to produce this toxin. And if you want to take out this phage action, so you can grow it with a anti-phage serum. So this phages will not be able to exert their action, and the toxicity will also be reduced. Clinically, it has a very short incubation period of 3 to 4 days. Okay, and most commonly, the type of infection what you're seen is a facial infection, laryngeal infection, nasal, otic, conjunctival, genital infection, and rarely cutaneous areas, which is mostly a secondary infection. Facial diphtheria, when you see, it's the most commonest type, and it has a wide range of clinical symptoms from a very simple inflammation to a very severe disease. So when you classify it, can divide to 3 types. You have a malignant or hypertoxic facial diphtheria, where there is a severe amount of toxemia with a marked adenitis, means the lymph nodes, everything will be enlarged, and it gives the appearance of a bull neck. Okay, and generally the death in these kind of patients is due to circulatory failure, and patients who recover from this might have a few paralytic complications. The second type is a septic variety, where there is an ulceration, cellulitis, or gangrene around the pseudomembrane which is formed on the tonsils. And the hemorrhagic type is where there is a bleeding from the edge of the membrane, or from there will be nasal bleed or conjunctival hemorrhage, purpura, or generalized bleeding tendency can be there. So this is the picture what I've taken just to show you the pseudomembrane. So complications, if you see, first of all, it is the asphyxia, because there is something obstructing the airflow, can cause of the pseudomembrane. There can be acute circulatory failure, it can be a cardiac circulatory failure or a peripheral circulatory failure. And the third one is a post-diphtheritic paralysis, which is mostly seen after third to fourth week of illness, where there is a paralysis of the palatine and ciliary muscles. Generally, these pupillary muscles will be spared, and slowly the patient will recover out of it. The next one is about sepsis. So where the infection spreads into a deeper parts, it can go in for pneumonia or otitis media. Toxemia, because the bacilli do not actually enter the bloodstream mostly, so they will remain there, and only the toxins are from the necrotic area will go into the bloodstream. So this exudate will mix with the epithelial cells, leukocytes, RBCs, and they will form a pseudomembrane at the tonsillar area. So mechanical complications will appear because of the obstruction due to the membrane, and the systemic complications will appear because of the toxin production. Now, the non-toxinic strains can also produce some infection, but generally an immunized patient does not give rise to a proper clinical picture, and the toxoid will not completely prevent the infections. It will just avoid the side effects or complications of the infection. Okay, and generally, whenever the patient or the person is immunized, the infection is very, very mild, and this passes off as another infection and not really goes into a proper full-blown diphtheria. So, diagnosis wise, you have to first of all look for the diphtheria bacillus, look for the toxin. So, to look for the diphtheria bacillus, since the bacilli is limited to the area of infection, you can take swabs from the lesions, and smears may not always be positive. And even if it is there, because there's other variety of Corynebacterium which does not really cause infection, it is not very easy to find out which is the one which is actually causing infection. So you have to identify the toxin producing potential. So here you have to look for toxinic bacteria using immunofluorescence staining if it is available. So the swabs can be inoculated into a Leopard's serum slope or tilted blood agar and sheep blood agar. Okay, so sheep blood agar is used to look for other causes of pharyngitis, and if the swabs cannot be immediately inoculated, you can just make the tip of the swab moist with the serum, and just to make sure that the bacteria survive. When you inoculate on Leopard's serum slope, the growth will appear within around 8 hours. Okay, and you can do a staining with methylene blue or any special stains, and you can titrate plates. If you're inoculated, you have to wait for at least 48 hours to see good amount of growth. And generally, as I said earlier, the samples are inoculated in titrate, which is from convalescents or contacts or carriers. Now, the most important part is the virulence testing. So here you have two different types. You have the in vivo testing and in vitro testing. So earlier, what they used to do was using the animal experiment or animal models. So generally, they will grow this bacterium on a culture medium overnight and nicely mix it in a broth solution. Take 0.8 ml of this solution and give it subcutaneously to 2 guinea pigs, and one of them is protected by giving a 500 units of antitoxin around a day before doing this experiment. So what happens if the strain is capable of producing a toxin? The animal will die within 1 to 4 days. Obviously, it is a cruelty, so it's not used now. A slightly more, uh, if you want, you can call it as a humane version. But one of the other animal experiments is intradermal testing, where you take 2 guinea pigs, you give 500 units of antitoxin to one guinea pig, and give 50 units of antitoxin intraperitoneally 4 hours before the procedure to the second guinea pig, that just to prevent death. Both of them will be injected with a zero point 0.1 ml of this bacterial suspension, and look for necrosis in the area of infection or in the area of injection within 48 to 72 hours. So in vivo testing is generally not available everywhere, and it is not possible also. So the next method is to go in for a in vitro precipitation, which is using our Elek'sGel precipitation test. For undergraduate students, it's very important to know about this test because it is very commonly asked. So here, what you do is you use a 20% horse serum agar. You can use rabbit or sheep serum also. So before the agar completely sets in, I'll just keep a small filter paper which has been soaked with 1,000 units of diphtherial antitoxin. And once the agar is set, you will make 3 streaks. That is a known positive toxin producing strain, known toxin non-producing strain, and third one will be your patient sample. Incubated for 37 degrees for 24 to 48 hours. What will happen is very simple. Or if the bacteria is able to produce a toxin, it will meet at somewhere along the equivalence where there's a toxin antitoxin mixing. So at the optimum concentration where the correct amount of toxin antitoxin meet, there will be a line of precipitation which will be formed. So obviously, the positive control or the toxin producing strain, it will give a proper line of precipitation. In a toxin non-producing strain, it will not give a line of precipitation. So with this, you can compare with your patient sample is giving a precipitation or not. So it will be seen as a arrowhead lines of precipitation. It's kind of easy, better to use, and it does not affect the animals. But some brands of the peptone can be a little bit interfering with this particular test. So this is the representative picture just to show how the test is done and how the streak lines are drawn on for Elek'sGel precipitation test. You can also do a tissue culture test where you are going to incorporate the strains of this bacteria, what you have recovered from the agar overlay of cell culture monolayers. And if it is the bacteria is capable of producing a toxin, it will kill the cells in this monolayer. Yes, on prophylaxis, which is most important. So you have 3 types. You have the active, which is basically the national immunization program or developing a herd immunity. Next one is passive, and there's a combined. So basically, the idea is to increase the levels of antitoxin. So in active immunization, what we do, it's a method where started way back in 1913. It was like a mixture of toxin and antitoxin. That is, if you mix equal amounts of toxin and antitoxin all at once, the particular mixture becomes completely non-toxic. But if you try to mix it in 2 different installments of toxin with antitoxin, the resulting mixture will still be toxic. Okay, so the current method, what is used, is 2 types. One is a formal toxide, where there's a toxin is taken out, incubated with formalin at 37 degrees with a neutral pH for 3 to 4 weeks. So we expect that the infectivity will be gone and only the immunogenicity will be maintained. The next one is absorbed toxin, where the purified toxide absorbed onto a aluminum insoluble aluminum compound. This is more immunogenic and it's now universally used. Generally, it's given as a IM dose in a national schedule. It is along with tetanus and pertussis. You can also have a quadruple vaccine that is along with the polio vaccination. The smaller children are immunized with the 10 to 25 units of diphtheria toxoid. Smaller doses can be used in older children and adults. So you look at the bottle, if there's a small d written, so that is your smaller doses, and for a full dose, it is mentioned in a capital D. So the schedule is generally around 3 doses of DPT vaccination, 4 to 6 weeks apart, and fourth dose maybe after a year. And if you properly look at the schedule, there will be a booster dose just at the time of the kid enters into the school. The next one is a passive prophylaxis where you already have a patient in your care which has already developed all clinical signs of diphtheria. So what do? You give 500 to 1000 units of antitoxin subcutaneously. So generally this antitoxin is taken from animals, horses. So there's a possibility of a hypersensitivity or a serum sickness reaction if you want. So you can also do a combined immunization. That is, as an emergency, you can use a antitoxin and the absorbed toxoid can be given in the other arm. So that will basically like the anti-diphtheria serum will cover the emergency time, help the patient recover, and the absorbed toxin will make sure that the slowly the body develops antitoxins by itself, and the patient will be um, immunized or will be protected for the future. So the full course of immunization, that is, all three vaccines have to be given. Treatment wise, you have the antitoxin, which has to be given immediately if there's a patient who is in already developed signs of the diphtheria infection. Generally, around 20,000 to 1 lakh units are used, and 50% is given as a IV dosage. Drugs, antibiotics, penicillin is a drug of choice, and for patients who are carriers not having an active infection, you can use erythromycin, which is supposed to be more effective in carriers. Okay, so this is a basic outlook or basic overview of Corynebacterium diphtheriae. So the most important areas where you have to concentrate as far as the exam point of view is concerned is basically from the type of bacterium, the growing media, that is your growth on Leopler serum slope as well as Pilroid agar, the different clinical presentations, and about uh, the testing, that is your how the diagnosis of Corynebacterium diphtheriae or clinically diphtheria infection. Hope I made it simple. And if there is any doubts or any clarifications, please feel free to comment, and we will get back to you with clarifications for the same. Thank you.